Knock, knock. Perform hand hygiene. Provide patient privacy. Hi, my name is Maya. I'm a student nurse at Chaffey College. May I please get your name and date of birth? Okay, Mr. Marshall, 1965. I'm going to verify that with your ID band, as well as the patient chart. Okay, do you have any allergies to any latex, bananas, kiwi, anything like that? No? Okay, so your physician has ordered a nasogastric tube procedure for you today, and what that is a nasogastric tube or catheter that is inserted through your nose into your esophagus and down into your stomach so that certain procedures can be performed. And some of these procedures entail an intermittent suction so that we can secrete any unwanted fluids, as well as feeding so that you will be able to get nutrition. Okay, so it shouldn't be painful. It might be a tad uncomfortable, but nothing we can't handle, right? Okay, so I'm going to go ahead and lower the bed rail, as well as raise the bed itself to accommodate my height. I'm going to don clean gloves. It is a clean procedure, not sterile. Alrighty. I'm going to make sure I have all my supplies, which include a Salem sump, Lopez valve, tape, emesis basin, a safety pin with a rubber band, tongue depressor, pen light, a 60 ml syringe, as well as water and some pH indicator strips. Alrighty, so we are going to begin. Do you have any history of any trauma to your nose, broken nose, any nasal surgery, sinuses, anything like that? Anything that I should be aware of before I start? No? Nasal polyps. I'm going to go ahead and take my pen light. If you can raise your head, I'm going to take a look in both of your nostrils just to better distinguish which nose that will be preferable before we begin. Okay. No occlusions, drainage, anything that I should know about upon starting. So I'm going to go ahead, I'm going to drape you with this towel, just in case the procedure gets a little messier than we intend. Okay, I'm going to take my Salem sump, open that right up, toss that in the trash. Also taking my Lopez valve, opening that up, tossing that in the trash. I'm going to put this in the emesis basin temporarily, and I'm going to take a look at my catheter. Make sure also to check the expiration dates of all my equipment and all my supplies. And we're going to take this blue tubing here, which is known as the pigtail valve of the Salem sump, and we're going to attach an anti-reflux valve, and I don't have one with me, but if you were to ever use the Salem sump, you would need the anti-reflux valve, which prevents any backflow or any complications, and we don't want to put anything else in the place of the anti-reflux valve, as it can occlude the designed flow of it. Okay, so let's go ahead and attach our Lopez valve to this opening here, right next to the pigtail valve. It's right there, that wide opening. We're going to take the Lopez valve, and we're going to take that small tapered end, the smallest tapered end, and we're going to apply it to that opening, nice and secure so it doesn't slip out. Perfect. All right, I'm just going to set that down right there, and I'm going to take this time to measure. So I'm going to take the very tip of the catheter, and I'm going to measure from the tip of the nose, the tip of the catheter, from the tip of the catheter to the tip of the nose, going to the earlobe here, and from the earlobe we're going to measure down to the xiphoid process, and you may have to move the towel up a bit so that you can get an accurate feel of where the xiphoid process is. I'm going to go all the way down till you feel that bony prominence there, the xiphoid process, and from there, that's going to be your indicator on your tubing. So you're going to take your small piece of tape, and you're going to indicate right where the xiphoid process was. Just like that. So that piece of tape will be your indicator on where to stop upon insertion. I know all of this sounds scary. I'm sorry. It's all part of the procedure, but everything will be okay. It's typically normal. Alrighty, so I'm going to take this time to open my 60 ml syringe so that I have it handy. Toss this in the trash. I'll have this here, set it down. Okay. Alrighty. So we are almost ready to begin, Mr. Marshall. So I'm going to take my tongue depressor, and if you can say ah, open your oral cavity. I'm just going to take a quick look, make sure that you don't have any loose broken teeth or any lesions or anything that might catch my attention or anything I should be aware of when I am performing the procedure. Okay, everything looks decent. So what we're going to do at this time, we are going to bend the catheter about 4 inches just so that it's easier to maneuver in the nasopharyngeal cavity. Okay, give it a little bend. May not always cooperate. Some hospitals and facilities also tend to cool or freeze the tubing so that it's really stiff and not so flexible and loose, and more steady so that it can travel more easily down the cavities. Okay, once it's bent to a pleasurable extent, we're going to take lubricant, and we're going to lubricate about 4 inches as well. And I also have a cup of water that I'm going to give you, and upon my command, you're going to take small sips as I fish the catheter down so that it can glide more smoothly. Okay. So here we go. You have your water. Prepare to take a few sips. Go ahead and tilt your head back so that we can get a good angle. Upon entering, on the count of 3, we're going to enter. 1, 2, 3. Okay. Once I reach the back of the nasal cavity, I'm going to ask that you tilt your head forward and continue to take small sips so that it can travel more easily. Go ahead, take another sip, please. Thank you. Another sip, and we've reached the xiphoid process as indicated by the strip of tape there. So we're going to go ahead and take the slightly bigger strip of tape to secure it to the nose. And to keep it in place. Oh, hold on, it's not quite in place. Make sure that it's secure so that it doesn't slip or slide out in any way. There we go. Nice and stable and secure. All right. So now we're going to check placement, and there's 4 ways to check that. The first being we're going to insert 20 ml of air into the stomach via the nasogastric tube while auscultating, and we are looking for a swooshing sound. The swooshing sound is our first indicator that it's in the right spot. The second indication would be the aspiration of gastric fluids which of course indicates that it's in the stomach. And the third indicator would be the reading of those gastric secretions, and based on the key card indicator, it would let us know the acidic or alkalinic contents of it. And the fourth and most accurate verification of placement would be an X-ray or KUB. So first, we're going to do that first indicator, and we are going to aspirate. So I'm going to lift up your gown here. Sorry if the stethoscope is cold. And I'm going to take the 60 ml syringe. I'm going to remove the capping, and I'm going to aspirate 20 ml of air, just like that. And I'm going to take my Lopez valve, and you always want to make sure that the on and off direction is in the right area to ensure non-leakage of gastric fluids as well as pertinent flow, depending on the procedure. So what we're going to do is we're going to go through this small port here at the very top. So we want to make sure that before we begin the procedure, once I applied the Lopez valve, I should have made sure that the off indicator is toward the nasogastric tube to prevent the leak of gastric fluid. So before you insert the tubing, when you apply the Lopez valve, be sure that the off indicator is going towards the tubing so that it prevents the backflow of gastric fluids. Okay, so here we're going to make sure that it is off. Now, before we insert the 20 ml of air, we want to make sure that the flow is pertinent to where we're going. So we're going to make sure that the off indicator is towards the feeding tube, which is this giant orange adapter here. We're going to make sure the off indicator is that way so that we can insert through this little port here. So it's going to be on towards the top, through towards the nasogastric tubing. Okay, but we don't want to cut it on until we're ready. So we're going to remove the orange cap. We're going to secure it there temporarily while I prepare my steth. Okay. Again, sorry, Mr. Marshall, if it's cold. We're going to make sure that we go underneath the skin, not over the towel, not over the gown, because we want to make sure that the sound, the swishing sound, is as accurate as possible. So we want to go to the left region. Okay. Left region of the stomach. That quadrant of your abdomen. Okay. Stethoscope is there. I want to make sure that the off valve is toward the nutrition adapter. So it is on up towards the tubing. Okay. So secure that, and I'm going to swiftly and abruptly push down. Okay, looking for that swishing sound. The swishing sound is the first indicator that the placement is correct, that is in fact in the stomach. Okay, excellent. So now I'm going to go ahead. And I'm going to slowly aspirate 5 to 10 ml of gastric content. Okay, there we go. And you always want to make sure before you remove the syringe, you always want to make sure that the valve is off in the proper area. So since we are done inserting air and aspirating gastric contents, we want to make sure that that area is sealed off, so to prevent backflow. So the off is toward the nutrition tubing section. We want to switch it towards the nasogastric tube section so that no gastric fluids can come back. So once we've done that, we can remove the syringe and we can reapply the cap just for safekeeping. We have the gastric content within. Okay, so we're going to take our blank pH strip. We're going to put it in the emesis basin and we're going to take the gastric contents and we're going to squirt just a little bit, few drops onto that pH strip, and we're going to give that a few minutes to read. And we're going to use the pH indicator to distinguish the acidity or alkalinic content of the fluid, and it will determine placement. Okay, so that should be enough time. And we have a yellow color. The yellow color, yellowish to orange color, as indicated by the pH key card, indicates that it is about 4 or less. 4 or less would indicate an acidic compound, and anything higher or any other sort of color, any blues or greens, would indicate an alkalinic pH, which would indicate that it's in the lungs or any other area that's other than the stomach. Okay, so that is our third indicator. Our fourth indicator would be a KUB or a X-ray, which would solidify that it's in the right spot. So we're going to order that for you. And being that we're comfortable for now where placement is, I'm going to secure the tubing even more to your nose, and I'm going to take this strip of tape that is 3/4 of the way torn down, and I'm going to wrap it securely, anchor it to the nose. Okay, I'm going to take that strip, one of the strips, and we're going to put it around the nose, and then we're going to take that other strip and place it around once again so that it's secure. And one last measure of securing it in place is taking a safety pin and a rubber band and we're going to take it, making sure that the patient can turn their head left and right, up and down, that they have slack. Okay, we're going to take that rubber band, we're going to loop it that way, and we're going to take the safety pin and just secure it to their gown, their shirt, whatever garment that they're wearing. We're just going to secure it to that so that it is another measure of keeping it in place. Okay. Alrighty then. So we're going to remove the gloves, throw these in the trash, perform hand hygiene. An extra measure to make sure that the Lopez valve, that the on and off switch is in the correct spot. We want to make sure that it's off towards the nasogastric tubing, making sure that the tape is secure, that the patient is comfortable. Are you comfortable, Mr. Marshall? I'm sorry about that procedure. I know it wasn't fun, but we got the hard part over with. So we're going to raise the bed rail. We're going to put the bed in its previous position. We're going to ask the resident if they prefer their head of bed elevated or down further. Okay, so we're going to perform that fourth indicator, and we're going to order that X-ray and KUB. And then I will be back shortly. Patient privacy. Okay. Alrighty, I will be back later. I'm going to exit the room. Return for the intermittent suction. Knock, knock, knock. Perform hand hygiene. provide patient privacy. Hi, it's Maya once again at Chaffey College. May I please get your name and date of birth once again? Mr. Marshall, birth date 1965, verify the ID band or the patient chart. Okay, so the doctor has ordered intermittent suction. There is a high and low intermittent suction, but we're going to be performing low intermittent suction as indicated by your physician's orders. So I'm going to don gloves. Okay, and I'm going to lower the bed rail. I'm going to elevate the head of the bed to accommodate my height. And we're going to check bowel sounds. So I'm going to lower the head of the bed, put them a bit flat so that it can accommodate the flattening of their abdomen so I could listen. So I'm going to listen to all 4 quadrants for a minute to confirm the presence of bowel sounds. Okay. Sorry if it's cold. Checking all 4 quadrants for bowel sounds. Okay, for a full minute each quadrant, total of 4 minutes. Okay, so bowel sounds are present. We can go ahead and perform that suction. So we're going to take the suctioning machine, which is typically on the wall of the facility. We're going to take that tubing and we're going to take the nasogastric tube with the low-pitched valve, and we're going to connect that tubing from the suctioning to the short tapered end. You're going to have to remove that orange adapter piece, and you're going to apply the suctioning to that area. So again, you want to make sure that flow is patent, and you're going to close the valve going up so that off is indicated upwards and on is indicated through the nasogastric tube. So it's going to go to the suction from the suctioning tube into that small tapered end to the nasogastric tube. Making sure that is on. We're going to go ahead and set to low intermittent suction per the MD orders. Okay, it is on. We're going to deglove, trash, hand hygiene, put the bed rail up, raise the head of the bed so that it's comfortable for the patient. Okay, and we're going to let the suction go, and we're going to give you privacy, and then we shall return shortly. I'm going to leave the room, and this is the discontinuation of the nasogastric tube. Knock, knock, knock. Perform hand hygiene, patient privacy. Hi, my name is Maya, once again at Chaffey College. May I please get your name and date of birth? Mr. Marshall, 1965. I'm going to read your ID band and check your chart. Okay, so the doctor has ordered discontinuation of the nasogastric tube. You will be discharging today. So I'm going to go ahead and apply clean gloves. Alrighty. And I'm going to lower the bed rail, and I'm going to elevate the bed itself to accommodate my height. Okay. So we're going to go ahead and remove the safety pin with the rubber band. We don't need it attached to you anymore since it's coming off. Okay, and we're going to remove the tape that is anchoring the nose. Just enough so that it's a little loose. It's still slightly secure so that it doesn't slide out. And we're going to gather a towel. We're going to wrap it securely around the tubing. Okay, Mr. Marshall, so on the count of 3, I'm going to slowly remove the nasogastric tube. It should be much more pleasant than the application of it. Okay, we're going to gently remove that tape now that we have a tight grip on it. Okay, we're going to take a deep breath in, and then upon exhalation, we're going to remove it. Okay, 1, 2, 3, and we're going to slowly pull that out. Slowly pull that out. There we go. And we're going to wrap it into the towel, being sure that we're cautious and aware of the catheter, that it doesn't fling all over the place and sling gastric fluids everywhere. We're going to ball that up. We're going to dispose of that in the trash. I'm going to deglove, perform hand hygiene, offer the patient any tissue or anything. How was that? Are you okay? Comfortable? Alrighty, the physician will be in shortly to discuss discharge planning with you, and we're going to put the bed rail up. We're going to lower the bed itself into its original position. Alrighty, Mr. Marshall. Well, you handled that very well, and I will see you soon. Thank you.